I know many of you. I'm Dr. Jeff Humbarger, one of the physicians at the clinic, filling in today for Dr. Stefan, who's been out on medical leave. He'll be back working next week, though. It's my pleasure today to introduce Dr. Parrott, Brandon Parrott. He works at the Center of Sight. He's a retinal specialist. He was trained at Bascom-Palmer Institute, where he was a resident and a fellow and chief resident. He has a lot of research experience. He also has an MD and PhD from Baylor University in Houston, and quite accomplished young man. Marianne asked me to give you several other announcements. After today's lecture, join us in the Women's Club for an informal reception, and you can meet Dr. Parrott. And then I'd like to thank our hostesses, Nancy Ireland, June Wright, Florida Field, Angela Stefan, and Corinne Bailey. And the next lecture is by Marianne Rudolph. Actually, it's now Protz, the therapist at Fitness Quest, who is going to be speaking of all the things that they can do for those of us who have back and extremity and neck and other kind of problems. And then in January, I'm going to talk about how to ruin your season. Dr. Parrott.
All right, well, I definitely want to thank you for the opportunity to come and speak today. Hopefully this is helpful. If it's not, please raise your hand and say, look, you didn't explain something well enough, or I have some questions about something that you're just talking about. Sorry about that. And more than happy to kind of interrupt and kind of take an aside. If there's a question you have, something about you personally or somebody you know, or something that I touched on that maybe I didn't flesh out well enough. I'm sure all of you in this room know somebody with macular degeneration. I'm sure you know somebody that has dry macular degeneration, somebody that has wet macular degeneration. It is very common. As our population ages, it's going to become more common. So this is actually hopefully a pretty useful topic, and I'll try to Sure. Let me turn up the microphone, put a little closer to my mouth. How's that? A little better? Okay. All right. We already went through this. So let me just start with the very basics. This is the first thing I say when somebody comes into my clinic, that the human eye is like a camera, okay? I'm a retina specialist. I have no idea what this stuff up front is. If it's your cornea or your cataract, I don't deal with that, okay? I'm joking. But all of you know about cataract surgery. How many people in this room have had cataract surgery? So a lot, okay? So that's the focusing part of the camera. That's the lens of the camera. So if you can get a good, nice, clean lens in there and they get the right size, then you can see great at distance or great at near, or if you have a certain type of lens, you can see great at both usually. And that's the lens of the camera. But I'm a retina specialist. I basically deal with what is the film of the camera. And your retina is really the film of the camera. And I tell people you can have the greatest lens in the world, but if you have damage to the retina, then you can't take a good picture. And again, this is just kind of a picture of the eye. And you've all heard of the macula. And the macula is really this tiny little area. So this is our whole eye here. And the eye is really hollow. There's this stuff called the vitreous on the inside. And I'm a vitreoretinal specialist, meaning I operate on the vitreous and the retina. And really the most important part of our vision is right here in the macula. This is a very, very tiny area. This area is actually just about 800 microns. That's tiny, and that's actually what determines about 90% of your central vision. Okay, so what is the retina? Well, the retina is basically like a circuit board. It's this layer of neural tissue in the back. It's nerve that takes in the light signals, pushes them through the nerve, and goes back to the brain and allows you to see, allows you to perceive light, color, motion, all these things. And basically it's just a complex series of circuits, photoreceptors, and different things that allow us to perceive vision. Probably all heard at some point that there's two types of photoreceptors, what actually detects light in the eye, the rods and the cones. What we worry about mostly is the cones, because that's really what gives us color vision. That's what allows us to read. That's what allows us to pick up the newspaper and read the sports section. The cones are mainly focused here in the macula, the very center part. And again, this is the most sensitive part of our vision, and that's why it's so very important, even though it's a relatively small part of our eye. It's a tiny part of our eye grand scheme of things. So what can go wrong? Well, I'm sure you've heard people talk about AMD. Well, that's just age-related macular degeneration. And the name really says it all, and that's why I kind of make a point of this. Macular degeneration is all about aging. You don't see macular degeneration in people who are 40. You don't see it in people who are 20. It starts to develop usually past 50, 55, 60, and that's really when it comes to manifest, because macular degeneration is truly a degeneration, like of all of our joints, skin, things like that. With time, insults build up in the macula, and that's what leads to the degeneration. It's very common. It's the leading cause of severe vision loss in adults over the age of 50. In fact, it's more common than breast cancer, prostate cancer, Parkinson's disease, and Alzheimer's disease all combined. So it's very, very common. Not always severe, but very common. And basically, it's a progressive disease. Generally will worsen over time, and it can worsen either rapidly or gradually, and I'll tell you why there's a difference in some people. And basically, it gets in the way of your common tasks. I can't tell you how important, you all know how important your vision is to your independence. That's the toughest thing I have to deal with on a daily basis as a clinician, is people who lose their independence. And by far, what I do as a retina specialist, I'm not always trying to get people 20/20. I'm not worried about if they have laser vision like a hawk. I need to keep you driving, I need to keep you reading, and I need to keep you, basically able to take care of yourself. My colleagues, the cataract surgeons, the corneal surgeons, they're trying for 20/20. I'm trying to keep you seeing and keeping you doing the things you enjoy as well as possible. So what are the symptoms of macular degeneration? Well, when the macula degenerates, a lot of people will sort of start to see what we call metamorphopsia, or sort of blurring or twisting of lines, distortion in their central vision. And that's basically because that macula, which is right in the center, builds up damage that creates distortion in the center of the vision. Sometimes rather than distortion or twisting of lines, they'll see a large kind of black spot, and it can be several different spots that are kind of in different places. But you kind of get the idea that when they're looking at something, everywhere they look in the center, that little black spot goes with them. So it's very frustrating to people because they look at their grandson's face or whatever, and they just can't make out the features anymore. They know who it is, they know where they are, but it's just very frustrating for them. So AMD is very prevalent, and when I say it's very prevalent, a lot of people have macular degeneration and it never particularly manifests that much. So about 1 in 10 people over 60 have macular degeneration. Now that may just mean that you have very early AMD, you may have a few drusen, you may not have severe vision loss, but it's very common. And then of course, as we age, it becomes more prevalent. So actually 1 in 4 over 70 has some degree of macular degeneration. And again, it's the leading cause of blindness in the Western world. And again, about 5 million new cases per year in Europe and North America alone. So what's the impact? So it's not just your vision. So for people that have macular degeneration versus people that don't, you can kind of see the effects here. Have nursing home admissions 3 years earlier, twice as many falls, 3 times as much depression, 4 times as many hip fractures, and deaths a full 2 years earlier than patients who are exactly matched who don't have macular degeneration. And they did some studies, kind of questioning people, and I guess this is not that important, but a lot of people said that they would trade 30% of their life if they could get their vision back to where it was before they had problems with macular degeneration, just kind of illustrating how important our vision is to us and how vital it is. Well, who gets AMD? It's largely a Caucasian disease. It's basically, you can see here, the causes of blindness, about 54% of Caucasians who are legally blind are secondary to AMD, less common in African Americans, and kind of halfway in between are Hispanics and Asians. So it tends to be a disease of Caucasians, and that's largely because of the genetics. And it's increasing. Okay, so in the year 2000, there were about 1.75 million people, not with just AMD, but with severe vision loss from AMD, with neovascular AMD, which is the wet form, or geographic atrophy, which is the worst of the dry form. And I'll go over what those two things mean. But you can see it's a huge increase. They've estimated by 2020 that it's going to be almost 3 million people who are going to suffer severe vision loss from macular degeneration. So clearly we talked about it decreases your quality of life. your driving, your near vision, your ability to read the newspaper. Leads to depression as people become somewhat limited by their vision. And I shouldn't say it be all gloom and doom. I have some patients who are doing fantastic even though they have terrible vision. And part of my role as a retina specialist also is to get people into low vision resources where they can see a low vision specialist that can teach them ways to use the vision that they have, teach them tools to use to get everything they can out of the visual potential that they have. And that's actually an important thing, and a lot of us as physicians kind of forget that sometimes, that it's not only important for us to we're so concentrated on making your vision the best that we can and doing this and doing that, that we forget that sometimes we just have to help you deal with the deficits that you have. And that's also an important aspect of being a retina surgeon and treating these kind of conditions. All right, so who doesn't know the difference between the dry and the wet form? Okay, all right. So there's basically two big divisions of macular degeneration. There's the dry and the wet. Dry has nothing to do with my eye burning, having to use tears, things like that. It has nothing to do with that. It's kind of poorly named, but it really has nothing to do with, quote unquote, having a dry eye. But there's the dry form of macular degeneration, which is generally less severe. And then there's the wet form, which is also known as neovascular macular degeneration. Again, the wet form. Thankfully, sorry, I keep hitting that. Thankfully, about 90% of people with AMD have the dry form, generally less severe, but unfortunately 10% have the wet form. So the only difference of that is when you actually talk about people who have severe vision loss. So if you come to one of my clinics, it's not 90% of my patients have dry and 10% have wet. It's more like 85% have wet and 15% have dry, because I'm seeing the people with severe vision loss who really need that next level of care, and those are the folks who unfortunately have the wet AMD and unfortunately have more serious potential visual complications from the disease. And again, if you look at the severe AMD, about 2/3 of those have the wet form versus the dry form. And I hope these pictures are somewhat useful. So the other question is, if you have advanced visual loss, do you have the wet form or the dry form? Well, really, it can be either. So I always tell people it's better to have the dry. It's always better to have the dry. But there are people who do have severe vision loss even from the dry form, and there are things that we can do to slow that down, and I'll discuss that a little bit. But this person at the top, this is what's called geographic atrophy. And this is where slowly over time, the retina develops these, I call them bare spots or worn out spots. It's like a bald spot on a tire. Essentially, your whole lifetime, this little area of your retina has been working very, very hard. And then over time, it starts to get these little spots that are worn out. And those spots eventually kind of group together to where it gives you sort of a pretty severe central blind spot. And that's where I showed you that picture with the big black circle in the middle. That's typically what people with geographic atrophy see. It usually progresses only very slowly, but again, can be very devastating. What you probably know, are a little more familiar with, is the wet form of macular degeneration. This is somebody who's developed a disciform scar in the central retina. And again, these patients probably have about the same vision. The difference is it probably took about 10 years for the patient, when the patient first started noticing in this, to where it got this severe, versus this could have happened over a month, really, quite honestly, because you can develop these scars and have severe visual loss very quickly with the wet macular degeneration. Okay. So people come in and they're always asking about, do I have the dry, do I have the wet? If I have the wet, did I have the dry? Well, generally, as a rule of thumb, almost everyone develops signs of the dry degeneration first, and there's an unlucky few of the people with dry who go on to progress to the wet form, because the wet is sort of like the next step up. And really, all we do when we treat the wet form is we shrink it back to the dry form, because we have great treatments for wet, but all it really does is turn it back into the dry and slow down visual loss, which can be very, very rapid with the wet form. And the other thing that's so unpredictable about this disease is that really there's no way to tell if or when the dry form will turn into the wet form. We have some ways to predict it, and I'll talk about that a little bit. But I can't tell you, a lot of people will come in, and understandably so, like, doc, I'm 89, am I ever going to have a problem with this? Am I going to be blind in 4 years, 6 years, 10 years? And you can't answer that question because there are a lot of people who have dry, it progresses very slowly, and they never have a problem. And there are people who unfortunately walk out the office and 6 weeks, 8 weeks later, they might develop the wet form, and then they're back in getting treatment on a regular basis to try to preserve their vision. And there's some genetic predictors and things that we can do to try to figure out who those people are, but with a 100% probability, we can never tell people. Okay. All right, well, let me talk a little bit more about the dry form. Okay. The first sign of the dry, and if you've seen your eye doctor, your optometrist, your ophthalmologist, retina specialist, at some point they probably said the word drusen. Okay. Drusen is just a deposit that's in the back of your eye. I tell people it's wear and tear pigment that builds up over time. So what happens is these little yellow spots, and you can kind of see them out here, kind of build up in the back of your retina. And they're really just waste products. So the retina is, has this high metabolic rate your whole life, and these little deposits of pigment build up in the back of your eye, and they collect underneath the retina. And in and of themselves, they really don't damage the retina that much, but they can lead to progressive atrophy of the retina if they get large enough and there are enough of them, or they do predispose you to developing the wet form or the neovascular form over time. And again, unfortunately, sometimes as these drusen build up and kind of glue together, you will develop this geographic atrophy. But again, the geographic atrophy is devastating, but thankfully a fairly uncommon form of the dry degeneration. Okay. And so any of you that have probably seen, even at this point, your optometrist or ophthalmologist or retina specialist, I'm sure they've done one of these things called an OCT. So who's had an OCT done? Okay, yeah, so quite a few. So just so you kind of know what you're looking at when they show it to you next time, I'm sure they probably explain it to you, but this is a cross-section of your retina. So this is literally a piece of beam of light that's gone into your retina, been reflected back, and formed an image of the different layers of the retina. This is your photoreceptors here. Kind of this is where the most important part of your retina is and where your vision originates. And you can kind of see here, this is a person with probably intermediate dry AMD. And you can see they have all these little bumps underneath the retina, and those are the drusen that, again, are just build up of the pigment products inside the eye. Again, this is just another example of an OCT where you see somebody that has geographic atrophy. And again, why I call this a worn-out spot or a bare patch is you can just see this is the corresponding area right here where the retina has basically just atrophied. Because if you lose that layer there to the atrophy, the whole retina above it kind of loses its support layer and kind of stops working as well. All right. So this is actually a pretty important thing to know, and when you see your doctor, you should kind of to nail them down about where exactly you are on this list. So this is what I was mentioning about, there are many, many forms of the dry macular degeneration. So when we say that, 1 in 10 people at the age of 60 or 1 in 4 people at the age of 70 have dry macular degeneration. Well, most of them are right here. They're in the early stages. And people with early usually don't lose that much vision, okay? If you took all the people with dry macular degeneration, about 75% of them would actually be in this early stage. And you really don't have a lot to worry about. Your doctor's like, oh, you have a few drusen, you have early AMD, maybe you should take the vitamins, maybe not. It kind of depends on your family history and some other issues. Unfortunately, a lot of those people will progress into what we call the intermediate form. Again, this is where you get medium and large drusen, much more frequent, and this actually is something that we worry about. So these patients are coming in, if you have this, the intermediate form, your doctors are asking you to come in a little more often, to take the Ocuvite, the AREDS vitamins, the Preservision, whatever your particular physician recommends, and also to monitor yourself with the Amsler grid with the little squares on it with the dot in the middle, things like that. And unfortunately, obviously, a few of those go on to the advanced geographic atrophy, which we really don't have much of a treatment for. Probably seen a little bit in the news about the implantable telescope. That has some applications in some people who haven't had cataract surgery. But again, it's kind of a limited amount of things that we can do medically for people with advanced AMD, although there are some good visual aids and low vision resources for folks. So again, dry AMD, most people don't have that much vision loss. And really the only treatment we have for it medically is vitamin supplementation. So I'm sure some of you are taking PreserVision, eye caps, Ocuvite, all these things. All these things are based on the age-related eye disease study, which was a National Eye Institute study looking at antioxidants and zinc supplementation and showing that it slowed the progression of dry AMD. So what these two studies did, and these were tremendously large studies, 10,000 patients each, run by National Eye Institute, very well-run studies. And basically what they showed, and the AREDS 2 data came out this summer, was that if you're taking this combination of vitamin C, vitamin E, zinc, and the copper to prevent zinc complications, lutein, and zeaxanthine, then you essentially lower your rate of progression of dry AMD by about 30%. So is it a cure? No. Is it designed to make you see better? Not really. The lutein and zeaxanthine may help a little, but really the point of the AREDS vitamins is to prevent and slow down the progression of the disease. Okay. One thing that it's not as important anymore because the formulas have changed quite a bit is that, again, vitamin E, you don't want to take too much of a supplement level. The first version of the AREDS formula, which is no longer in the AREDS 2 formula, had beta-carotene, which you don't really want to take if you're a smoker. It gives higher rates of lung cancer even than baseline smoking alone. And that used to be important, but basically there are very few of the supplements that have beta-carotene in them anymore. So what can you do besides just medically? Well, the biggest thing that you can do is smoking. You know, when I see terrible dry AMD, especially in a male, I hate to be a little stereotypical, first thing I ask them is, how long did you smoke? Are you still smoking? All those sorts of questions. And I find, you know, almost without fail, you know, they've been smoking for 50 years, you know, since they were 16, 17, whatever. And that is the #1 modifiable risk factor for macular degeneration that you can do something about. Now, I realize it's hard to stop smoking. I have a father that smokes and will probably smoke to the day he dies. But, you know, that is the one thing that you can definitely do for yourself. Being a smoker raises your level of risk of the disease over threefold over the normal population. Things that you can do, your diet. Your diet is actually very important. People who eat lots of fruit and vegetables, carotenoids, red peppers, things like that, corn, etc., and a lot of fruits and vegetables rich in antioxidants, they get a lot less AMD. So diet is definitely important. And we think that it's because if you're eating a healthy diet, you're not getting as much fat, you're not generating as many free radicals, you're getting a lot more antioxidants in your system that we know are good for many things, your heart, macular health, etc. Other things you can do. Blood pressure. Blood pressure is actually very much a factor with AMD. People with poorly controlled or high blood pressure definitely get more advanced AMD at a much higher rate. The next thing is actually a little bit in debate. So the omega-3s, I'm sure a lot of you are taking it either for dry eye or for your cardiac health. I'm not sure what you recommend, but we used to think that it was very, very helpful for the dry macular degeneration also. There were a couple studies that said it were great. Most recent AREDS 2 didn't quite show so much support for taking omega-3s, but we still think obviously a diet, and it's without doubt that the population studies showed that people with high omega-3 in their diet, again, did much better, had much less macular degeneration, and much less visual loss over the long term. And also physically active. Getting exercise, lower rates of AMD. I basically, when I'm talking to patients, I say, if your cardiologist or your regular internist told you that it's good for your heart, it's probably good for your macular degeneration because it's the same sort of oxidative damage, the same sort of things that are harming your heart or harming your eye. All right. So this kind of shows the big difference of why we worry about the dry versus the wet. The dry goes very slowly, but someone can be blinded by wet macular degeneration literally within days sometimes, but definitely within weeks. So what is wet AMD or neovascular AMD? Well, what happens in neovascular AMD is that there's tiny blood vessels that grow off the normal blood vessels. Okay? We need the normal blood vessels. They're feeding our retina, they're letting us see, they're doing important things. But for some reason in macular degeneration, we start to get growth of new vessels that are not supposed to be there. And I tell my patients they are not as good as the factory original. So what happens, these vessels, they grow, they break, they bleed, so they cause hemorrhage, fluid into the retina, and ends up causing scarring and basically visual loss. And again, this is a patient that has wet AMD. You can see here they've developed a pigmented scar. They have some active hemorrhage. And this person's vision is probably very poor, probably about 2200 or 2400 or so. And again, the thing that's so tough about this is that it can be very rapid. And I'll have patients who come in and they say, oh, you know, I had my appointment a year ago and I was doing fine. I was seeing 2020 and 2025 and I was doing great. And I don't know, a couple months ago I wasn't seeing as well. And you know, I come in and they come into the office and suddenly their hand motion or 2400 or just count fingers vision in one eye. And I look in and I see a big, huge scar like this. And most of the time I tell them, I was like, we're going to stop the progression of the disease, but that there may not be a lot I can do for you because we just got to it too late. And those are patients, obviously, we're surveilling their other eye very, very carefully because if you get it in one eye, there's always a chance of getting it in the other. So they definitely get a very attentive level of care. This is probably more than you need to know, but wet AMD is basically caused by what we call membranes or choroidal neovascular membranes. And these are just small little vessels that grow from underneath up into the retina and cause this bleeding and swelling and edema and basically decrease the vision in that manner. And again, the way I sort of talk about this is, you know, the drusen that are there are weakening the basement membrane or the bottom part of your retina. And these little vessels are actually growing up kind of like weeds in the cracks of the concrete. They're basically getting into your retina, bleeding, causing scarring and stretching, and basically being destructive to the integrity of the retina. And again, this is sort of the early and the late, what you see in choroidal neovascularization. A lot of people will come in with, say, decreased vision. This patient probably sees about 20/80. I say, Doc, I'm having terrible distortion. My vision is down in this left eye. And if we get somebody like this, we can generally treat them and get them very much improved vision. They'll generally get 2 or 3 lines of vision back at least, and we'll be able to stabilize that for several years, usually. Versus if this goes untreated, it ends up making this large disciform scar. And again, this is something that unfortunately, all of us as retina doctors face with nothing that we can do at that point. So I don't want to ask 2 pointed medical questions, but are any of you getting injections? Okay, okay. Anybody had laser 10, 15 years ago for macular degeneration? It's a little surprising. So the change in the treatment for wet AMD has radically changed over the last 10 to 15 years. Back before 2000, all we had was thermal laser, which for most people was both devastating to the patient and devastating to the doctor, quite honestly, because all we could do about a decade and a half ago was literally just laser the center of the person's eye, basically blinding them, at least in the center. And we knew the studies showed that over the long term, they did better if we did that, but over the short term, they acutely lost vision. But that was the best we had, and that's really all we had until 2000. In 2000, there was something that came out called PDT or Visudyne. This is what your doctors may have described as the cold laser. This was a better treatment than the thermal laser. It wasn't as destructive to the eye, but people still lost vision over time. They didn't gain vision, it just slowed down the progression. And then in 2005, there was a product that had a very brief life cycle called Macugen. This was the first of the anti-VEGF drugs that we started injecting into the eye. It helped people, but still only slowed their rate of visual loss. And then around 2005 came the advent of Avastin treatments, Lucentis, and later VEGF trap eye, which is actually known as Eylea. All these things started to go into clinical trials. Some were in clinical trials. We were using Avastin in the clinic. And I actually, I was a very lucky retina surgeon in that I literally kind of came into this in 2005. I really didn't have to live through these, kind of blinding patients with laser, doing things. I can remember as an intern doing my, seeing the first Macugen injection. So I really never trained in the non-anti-VEGF era. And it has been an enormous benefit for most people's vision. And the results have been vastly superior than what we had in the past. Again, this is what I was saying about laser. All we used to be able to do was try to laser the lesion that was there.